Good evening, the respected chairperson and respected guest and learned audience. Assalamu alaikum. Me myself, Dr. Mohammad Tariqul Islam, Assistant Professor of Critical Care Medicine in Dhaka Medical College. Welcome to my session on sepsis biomarker. It's very important. But first of all, I would like to present some case scenario for my resident and students. I would like to some interaction after my session. This is the first case scenario of a gentleman with TB and BEP who the investigation shows raised WBC, tracheal aspirate shows the growth of Acinetobacter, and the chest X-ray shows opacity but procal negative. What is the explanation behind of it? Then my second case scenario, the 23-year-old lady at the 65th day of ICU admission, the investigation shows CBC, CRP, and procal normal, and the tracheal aspirate growth shows the Klebsiella. This is the third case scenario, a 40 years old male. His diagnosis was decompressive cranectomy. Investigation shows the raised CBC, CRP, opacity of the chest X-ray, but culture sensitivity was negative. And the fourth and most important case scenario, this is a case of post-status craniotomy due to subdural hematoma. When at the 20th day of hospital admission, report shows 5 multi-drug resistant organism, but culture sensitivity shows only Klebsiella, where the chest X-ray shows bilateral consolidation and the procalcitonin negative. So what are the explanation behind of this scenario? I would like to discuss after my session. So I would like to focus on the understanding of the sepsis and its challenge, and understanding the CRP, procal, and multiplex PCR, and compare between among them, and identify the myth and limitation about the biomarker and application of this in clinical practice. So we all know about, and Dr. Saurabh has gone through the sepsis slide, but I'd like to focus some important point about on it. That is the sepsis. We know that sepsis is a life-threatening organ dysfunction due to dysregulated host response to infection. So it is a medical emergency and notorious condition. There is a high ICU mortality, which required early recognition. If there is any delay of recognition, there may be higher mortality. And also there is an emergence of multi-drug resistance also is a problem to select antibiotics for the management of the sepsis. So for that, we have to follow an antibiotic principle, that is antibiotic stewardship. We know, all of you know that there is some condition where infection or non-infective cause maybe coincide or maybe similarities of picture of the presentation. So we have to first exclude the non-infective cause from the infective cause to prescribe antibiotics, and also to avoid overprescription or irrational use of antibiotics. So we should start smartly, then focus on a single antibiotics. That is the antibiotic stewardship. সো আমি যে জিনিসটা ফোকাস করতে চাচ্ছি যে আমরা ইনফেকশন মনে করে অনেক সময় অ্যান্টিবায়োটিক দিয়ে ফেলি, যেটা আসলে ইনফেকশন ছিল না, নন ইনফেক্টিভ কজ। সো যখনই আমরা ইনফেকশন মনে করব, সৌরভ যেটা বলে গেছিলেন যে 1 ঘন্টার মধ্যে অবশ্যই অ্যান্টিবায়োটিক দিতে হবে, তবে সেখানে আমাদেরকে কনফার্ম করতে হবে যে এটা ডেফিনিট সেপসিস, আইদার পসিবল। যদি পসিবল বা প্রবেবল না হয়, অবশ্যই আমাদেরকে অ্যান্টিবায়োটিক বন্ধ করে দিতে হবে অথবা ডিএসকেলেশন করতে হবে। তা আমাদের এইখানটাতেই সমস্যা যে আমরা কিভাবে শিওর হব বা কিভাবে নিশ্চিত হব যে এটা ইনফেক্টিভ কজ নাকি নন ইনফেক্টিভ কজ। দেন উই শুড ফোকাস অন দ্য টার্গেটেড থেরাপি অর স্পেসিফিক থেরাপি অ্যাকর্ডিং টু কালচার সেন্সিটিভিটি। বাট প্রবলেম ইজ দ্যাট we have to get the culture sensitivity that needs at least 42 to 72 hours. So that is the big challenge for the diagnosis of the sepsis. So there is and I also told about that there is a non-specific symptom, fever not always present in sepsis, there is a delay in diagnosis, delay in blood culture, and sometimes there may be culture negative sepsis. So all of these are the diagnostic challenge for the sepsis. So biomarker can help for the early diagnosis of sepsis, or exclude the non-infective cause from the infective cause, and also to detect the multi-drug resistant gene, and also monitoring the antibiotic therapies and antibiotic stewardship as well. So what we search, we have searched a ideal sepsis biomarker, but there are so many biomarkers, so many investigation, but we can through a 7C framework, that is CBC, CRP, Procel, culture, chest X-ray, CSF, and PCR, along with the clinical context. আমি আমার স্টুডেন্টদেরকে সবসময় বলি যে আমরা যখন সেপসিস চিন্তা করব, আমরা এই 7Cটাকে ফলো করতে পারি অ্যাজ এ নেমোনিক্স অথবা মনে রাখার জন্য, যাতে কোনো কিছু মিস না হয়। So ideal biomarker should be rapid, sensitive, specific, and cost-effective, and also reproducible, easily available. But none of the biomarker will fulfill all the criteria. So we go through our CRP, that is a traditional biomarker, that is a main working horse, and that is produced by the hepatocyte, stimulated by the interleukin 6, and it is rises at 4 to 6 hours and goes peak about at the 72 hours. The CRP is a traditional and which is cheap, widely available, easy to measure, and useful for monitoring of the inflammation trend. অনেক রিউমাটোলজিস্ট এখনো বিভিন্ন রিউমাটোলজিক্যাল ডিজিজের জন্য সিআরপি করা হয়, সেই জিনিসটাই আমরা সেপসিসের জন্য কাজে লাগাতে পারি, যেটা ইনফেকশন মনিটরিং, ট্রিটমেন্ট রেসপন্স অ্যাসেসমেন্ট, ইভেন পোস্ট অপারেটিভ সার্ভিলেন্সের জন্য। Problem is the CRP can rises falsely in trauma, surgery, burn, malignancy, and autoimmune disease. But still, CRP is sensitive, but not specific due to false rise of CRP in different medical conditions. Some myth about the CRP is specific the bacterial sepsis rises immediately. Both are false, but still CRP is a player in the biomarker team. The next, the procalcitonin, the main antibiotic stewardship tool, which is the precursor of calcitonin and released during the bacterial sepsis. And we can use the procalcitonin as a differentiating marker from the infective cause from the non-infective cause. And there is an early riser than the CRP. We can check that it is rises within 2 to 4 hours and goes peak within 12 to 24 hours. So what is the advantage of the Procal? It is more specific than the CRP. Earlier rise, useful for serial trend, not a single marker or not a single test. That should be do a serial trend, as a serial marker to check the monitoring of the antibiotic response. In clinical practice, we can use for the early detection, ICU sepsis evaluation, antibiotic stewardship, and monitoring of the treatment response. But there is still limitation. There is a false rising also in major surgery, trauma, burn, pancreatitis, malaria, and also false low values in early infection, localized infection. So Procal should be complement, not a replace of clinical judgment. There is also myth about the high Procal always means sepsis, low Procal always exclude the bacterial sepsis. Both are false. Procal may be normal in early sepsis or in localized infection. And another important point is the serial Procal trends more useful than the single values. Then the important issues, multiplex PCR, the last frontier, which detect the multiple pathogen with resistance gene, which is a rapid molecular diagnostic test. Some example, BioFire, Septifire, T2Bac, Eplex, all are the multiplex PCR platform that diagnose rapidly with high sensitivity, early organism detection. These are the example of so many types of multiplex PCR available all over the world. But what are the limitations of the multiplex PCR? One of it is not available all over the country, and another issue is very much expensive. And the third important and also important that they may not detect always the viable it also detect the non-viable organism also. So multiplex PCR is a part, but should not blood culture should not replace the blood culture. Blood culture should remain the gold standard. So what are the myth about the PCR? PCR replace the culture, false. PCR detect all pathogen, false. PCR is rapid, that is true. If we compare CRP, Procal, and multiplex PCR, Procal is earlier, multiplex is also rapid and earlier than the CRP. And in the term of cost effective, multiplex PCR is very high cost and compared to CRP. Procal also a high value investigation. And multiplex PCR directly detect the pathogen, but CRP Procal is an indirect evidence of sepsis as a biomarker. So what are the future direction for the sepsis and sepsis biomarker? There is a pre-sepsin, interleukin 6, MDW, monocyte distribution with transcriptomics, AI assistant diagnosis, and future trend for the sepsis biomarker, precision of the medicine, that is individualized medicine, individual prescription, multi-maker panel. So may I ask the resident or the students to participate in the case scenarios? The first scenario was all the parameters like WBC, chest X-ray shows opacity, culture shows also organism, but Procal negative. Localized infection. Then the second, CBC, CRP, Procal, normal, but there is a tracheal aspirate shows growth of Klebsiella pneumonia. Any answer from the audience? Contamination or colonization. Third case, 40 years old male diagnosed as a case of decompressive craniectomy. Investigation shows CBC, CRP, opacity chest, but culture negative. It is also possible there is sepsis with culture negative. There is culture negative sepsis also. This is the important on which we depends more for the sepsis diagnosis. This is the post-status craniotomy status and 20th day of hospital admission. Report shows 5 notorious organism with multiple resistant gene, but culture shows only one, Klebsiella. And Procal normal, negative. So what is the expected present in the airway? So we should cautious about the reports and also prescribe the antibiotics. So my take-home message: no single perfect biomarker exists. No single. We should follow multi-parameter screening tool, and CRP still remain useful for checking the trend of inflammation. Procalcitonin aids antibiotic stewardship, and multiplex PCR improve rapid diagnosis. Still, the blood culture remains the gold standard. After all, the clinical correlation, physician judgment is important.